Tonight's presentation is a very important one entitled Primary Care of HIV Patients. And to present for us is the very distinguished Dr. John Applebaum. Dr. Applebaum is an internist, a geriatrician, a hospice palliative care physician, and an HIV expert. He's a graduate of the University of Miami School of Medicine and the University of Massachusetts Internal Medicine Residency Program. Currently, he serves as the director of the Internal Medicine Education at Florida State University College of Medicine. In addition to teaching, he continues to provide primary care and HIV care in the underserved populations. This presentation has been approved for 1 hour of CE credit through AAFP. And also, I wanted to let you know that we're going to have question and answers tonight that can be presented throughout the presentation. If you look at the bottom left-hand corner of your screen, you'll see a Q&A box. Please feel free to submit your questions and or comments throughout the presentation, and Dr. Applebaum will address them as he goes along. Additionally, I think there will be some breaks for questions as well as at the end. So with all of that said, ladies and gentlemen, let's welcome Dr. Applebaum.
Thank you, Sabrina, and I'm glad that you all could join tonight, and I'm happy to see that those of you who joined us have had some experience with caring for HIV patients. So let me go ahead and advance the slide here. So Sabrina, okay, there we go. So anyway, I don't have any financial or other relationships to declare. And the things we're going to talk about tonight, I thought first let's review the demographics of the HIV pandemic in the United States. I want to just review the life cycle of the HIV virus because that's important when we talk about treatment, and describe what the current recommendations are for testing and treating HIV infection. This is a area that is always in a state of flux. I want to talk about approaches to HIV prevention because that's still the best way of trying to get this epidemic under control, and then talk about the current drugs that we use to treat HIV infection and some of the common side effects of those medications. We'll talk about some of the issues that you all must be dealing with, which are what are the barriers to treatment. And then finally end up with some additional areas of concern in how you care for HIV-infected patients. So a lot to cover. I'm open to questions anytime you have any, and I'll stop periodically and ask for questions. So let's start with the demographics. And this data goes back to 2009. And just so you're aware, the CDC is usually about 2 or more years behind in disseminating data around HIV and AIDS information. But this is just to highlight the areas that are the epicenters of the HIV infection. The purple areas are the areas that have the most new diagnoses. Unfortunately, when the data was collected, some of the areas like California and Massachusetts were not included. But certainly Texas, Florida, where I reside, and the Northeast are areas of prevalence of the disease. Rates of diagnosis, not a surprise. The same areas have high rates, but the southeast part of the United States, let me get my arrow here, is the area that has the highest rate of new infections of HIV. And it's an area that many of us are very concerned about. The next slide just shows the prevalence of the disease. So we looked at incidence, rates of infection, and now we're looking at prevalence. Again, no surprise, same areas are lighting up. And as I said before, certainly if we were collecting data on California or had data on California, that would also be a purple area. So to review a little bit about HIV, remember it's a RNA virus. Viruses need other cellular machinery to reproduce, and that's exactly what the HIV virus does. It has a specific receptor that attaches to the CD4 cell, which is virtually the only cell in the body, with minor exception, that gets infected by the HIV virus. It attaches through this receptor. Let me just show it to you here with the arrow. Here is the receptor right here. And on the left and on the right, you see these are co-receptors that are also important in the attachment of the HIV virus to the cell. And after attachment, what happens is the virus injects its genetic material. Okay, let me get my arrow here. Right where the arrow is, the virus injects its genetic material, usurps the machinery of the CD4 cell to reproduce the virus using an enzyme called reverse transcriptase. Remember, our body requires, the genetic material is in the form of DNA. The HIV virus is in the form of RNA, so the reverse transcriptase basically takes the viral RNA, converts it to DNA, and then on the next slide, it shows what happens is that the viral genetic material, which is now in the form of DNA, gets integrated into our cellular DNA, and that's how the virus then takes over the cellular machinery and reproduces billions of copies of itself, and that's what's shown here with the blue. And then after that, what happens is that the virus repackages itself. It basically buds out of the CD4 cell and then back into the bloodstream. And a single CD4 cell so infected can produce billions of HIV viruses. And this is a depiction of what happens when the virus is released. Okay, so given what we've just talked about, you can see that there are a number of different targets for treating this infection. We can target the, again using my arrow here, we can target the attachment and the fusion of the virus to the cell. We can target the reverse transcriptase enzyme of the virus. We can target the integrase enzyme of the virus, and we can target the protease enzyme of the virus. And we have drugs now available that use all these targets. Another target that we've been having difficulty finding a drug that's effective is this assembly and release portion of the viral life cycle. Okay, so what we're going to do is we're going to use a case to show you some examples of how you care for patients who are at risk for HIV. So this may be a patient very similar to someone you may be seeing in your clinic. She's a 33-year-old black woman. She's coming to visit you for the first time. As you take her medical history, she mentions that she's had an abnormal pap smear a few years ago. You ask her if she's ever been tested for HIV, and she says no, and she also tells you that she's confident that she's not acquired HIV. So question for you all, is there a basis for you to encourage her to be tested at this time? And we can pause a little bit and see if anybody wants to comment on that. Well, if not, I'm going to move on, and the answer to that is basically yes. So actually, 5 years ago now, in 2006, the CDC changed its recommendations for routine HIV testing, and this was the CDC guidelines, and probably the most important is what I've outlined in red there, which is that any patient aged 13 to 64 years of age, regardless of how you assess their risk for HIV, it's recommended that they have routine HIV testing in all healthcare settings. Unfortunately, many people have not implemented these recommendations, and they're still quite a number of barriers up there that prevent people from performing routine HIV testing even 5 years later. But that's a topic perhaps of another discussion. So again, this is a time where we can review HIV transmission and prevention. So remember that the body fluids that can transmit HIV are only blood, semen, and vaginal secretions. So it's not sputum, it's not urine, it's not saliva, and it's not feces. Another important way HIV can be transmitted is what we call vertical transmission from a mother to child at birth, during gestation, or even during breastfeeding. So the way we would counsel patients in an attempt to reduce risk and to prevent transmission of HIV is safer sex. So using barrier methods, counseling our injection drug users to try to use clean needles and syringes, and certainly no sharing of needles. And then for those of us in the healthcare arena is to remember that occupational blood exposure should be minimized using infection control procedures and universal precautions. It's important that in primary care that we incorporate prevention strategies into our patient care, and that's regardless of whether our patient is known to be HIV infected or we don't know their HIV status. So we need to get two messages out. So for our HIV infected patients, we need to make sure that they understand that they can transmit HIV to an uninfected partner. So we need to be very clear in expressing, or first of all, assessing their education and their knowledge, but to communicate prevention messages that they understand. We need to be able to ask them questions regarding their sexual and drug use behavior, and if they are a substance user, to refer them for treatment, to talk to them about partner notification, and importantly, because we know HIV can be, the risk of transmission of HIV increases if they have other STDs, so we need to screen and treat for other STDs. For HIV negative patients, we need to assess their risk, but we also need to be providing primary care and to do preventive screening for HIV as part of primary care. And again, if they themselves have issues around HIV risk behavior, we need to refer them for evaluation and treatment. So what are some of the things that we know work to prevent HIV? Obviously, education and behavior modification. We already mentioned getting patients into drug and alcohol abuse treatment, using clean syringes, using barrier methods for safer sex. Male circumcision has been shown certainly in Africa to prevent HIV transmission between heterosexual couples, not been shown to have any effect on men who have sex with men, although that has not really been looked at very well. We do know that knowing the status of the mother during pregnancy and delivery will decrease the risk of transmission to the child if appropriate treatment is instituted. Topical microbicides are sort of a new hot topic. Microbicides that contain small amounts of anti-HIV medications have been shown to decrease the risk of transmission. Pre-exposure prophylaxis, let's start with post-exposure prophylaxis. We know that from the occupational healthcare workers, that prevents HIV infection, and there have been a number of non-occupational exposure trials that have shown also that works. Pre-exposure prophylaxis also gotten some press in the last year, showing that certainly for men who have sex with men, the trial that was publicized last year, there was a 44% reduction in transmission between homosexual couples. As I said before, treatment of other sexually transmitted disease, especially diseases like syphilis, are important. Vaccination, unfortunately, vaccination trials have not been all that successful, although one in Thailand did show a modest reduction using a preventative vaccine. And I put in bold early treatment of HIV, something that many public health officials have advocated, but only recently do we actually have really good data that early treatment, regardless of CD4 count and viral load, will decrease the spread of HIV to uninfected persons. Just a little bit of review about the infection. Remember, once a patient is infected, if you look at the yellow line here, their viral load increases dramatically, but then comes down and plateaus to what we call a set point. And this set point may slowly increase over time, but basically remains fairly stable for up to 10 to 12 years before it begins to rise. Conversely, the CD4 count here shown in, I think this is an orange color, will very, very rapidly decline in the setting of acute HIV infection to very, very low levels, sometimes even lower than what it's shown here, but then bounces back again to kind of a set point that slowly drifts down over time and until the patient develops AIDS. And there are different phases of the disease, from the acute phase where the patient may be asymptomatic to having an acute infectious mono-like illness to just having persistent swollen lymph nodes, to a chronic phase where they may have minimal, if any, symptoms, to frank AIDS, which I've listed some of the diagnoses on the right, but that's not a complete list. So early diagnosis and getting patients into care is probably the most important way to improve survival, and now with the new data decrease the rate of new infections of HIV. The unfortunate thing that even here in the United States, and this is data from just a couple of years ago, most patients unfortunately aren't diagnosed until the later stages of HIV. And the United States actually lags behind Western Europe in what the average CD4 count at diagnosis is. And many patients still get diagnosed with a CD4 count of under 200, which means that they are diagnosed with the diagnosis of AIDS. So when do you start to treat? There are two sets of guidelines that are followed in the United States. This is the International AIDS Society USA guidelines from last year. They haven't really changed much this year. The other set of guidelines is the DHHS, the Department of Health and Human Services guidelines, which were recently revised in January of this year. Similar, although I will say the IAS-USA guidelines are probably much more liberal, and most of us are following these guidelines in that they're recommending, as you can see now, that if a CD4 count is less than 500 cells, they are recommending that a patient begin HAART being highly active antiretroviral therapy, or the combination therapy that we use to treat HIV. And if you look at the line below, that even the recommendation is that any CD4 count, even if it's above 500, that therapy should be considered. And I think a lot of that goes to the public health issue and the fact that the therapies now seem to be much better tolerated, and that there's some evidence that early treatment may preserve the immune system. Now, there are some conditions that, regardless of what the CD4 cell count is at diagnosis, do require the patient go on treatment. Certainly, if they have any symptomatic manifestations of HIV, or if they have an acute opportunistic infection. But patients that you might see would be any pregnant woman it's recommended that regardless of CD4 count that they be started on antiretroviral therapy. A population that I'm particularly interested in, which is older patients. Age is a poor predictor of how someone will do with HIV. So any older patient, particularly older than 60, should go on antiretroviral therapy. High viral loads, patients who have a rapid decline in CD4 count, any patient who has active hepatitis B or hepatitis C, any patient who is at risk for cardiovascular disease, because it appears that HIV itself may be a cardiovascular risk factor. Symptomatic primary HIV infection. Now this is a little controversial, so if you happen to have a patient in front of you with acute HIV infection, it is a little bit controversial. Some treaters recommend that those patients go on antiretroviral therapy immediately. Others still say wait. HIVN, which is HIV-associated nephropathy, particularly bad renal disease, which is more common in African American patients, may lead to rapid renal failure and the need for dialysis, is an indication to go ahead and start HIV therapy, because those folks actually do better and preserve renal function if you start them on antiretroviral therapy. And certainly serodiscordant couples, it may be a reason to start them on the infected partner on antiretroviral therapy. I'll stop here and ask if anybody has any questions on what I've just covered.
Dr. Applebaum, while we're waiting for people to type in, I was curious, what do you attribute the higher rates of HIV infection in the Southeast to?
Well, that's a good question. I think some of it is related to maybe problems with access to care. I think there's a lot of stigma around HIV. Certainly the data that we've seen, particularly from North Carolina, which has a really good accounting of patients in their public health system, many of the women of color are infected from their male partners who may actually be having sex with men on the side, something we call the down low. So I think there are issues around access, there are issues around bisexuality. So I think those are the major reasons. So let's see, we got a couple of questions. Is it possible to get copies of the PowerPoint? Yeah, absolutely. I don't have a problem with that. And let's see. Why do those with active hepatitis B virus or hepatitis C infection start HAART? Okay, good question. So certainly with hepatitis B, the issue there is that some of the drugs we use to treat HIV are actually drugs that are used to treat hepatitis B. And so you need to carefully look at your drug therapy for the HIV, because you don't want to undertreat or perhaps promote resistance to hepatitis B. So that's the recommendation, is that if you're going to treat the HIV in a patient who's got hepatitis B, you're going to go ahead and use a therapy that's going to take care of both. The hepatitis C, the reason there is that there's good data that patients with hepatitis C who are co-infected with HIV actually do worse. The HIV makes the hepatitis C worse, and the hepatitis C makes the HIV worse. So the recommendation there is that, again, you try to treat both. So that is the answer to that question. So I think I'll go on to the next slide here. So we're back to our patient. So our patient does test positive for HIV-1 infection. After informing the patient about our diagnosis, which tests related to HIV should be performed immediately in addition to the CD4 count and a viral load? So I'll wait and see whether anybody wants to answer that. Why don't I go on and tell you what I would recommend? Okay, so we're going to be recommending, let me get my arrow here. We're going to recommend tests related to our HIV infection, but also a number of other tests. And let me go over why we're ordering what we're ordering. Let me get rid of my arrow here. Okay, so we talked about CD4 count and viral load. The other thing we always do on and I got actually some people who have responded. So the other test you're going to do immediately is a genotype resistance testing. And why do we do that? The reason for that is depending upon the part of the country you live in, there is a pool of resistant virus in your community. It varies. In some areas of the country it's very low, you know, a couple of %. But some of the large urban areas, it may be as high as 15% to certain drugs. And what you don't want to do is give a patient a medication that they're already resistant to, because one of the sort of the rules of treatment of HIV is you'll never have a better chance of getting the virus under control than you will have the very first regimen you put the patient on. So you really want to do the best you can for your patient, so you want to know as much information about that particular virus. So the other test you're going to want to do, you want to do a CBC. Patients with HIV can have anemia, they can have thrombocytopenia. You want to do basic serum chemistries. You certainly want to do liver function tests. Lipid panel is a good idea as a baseline. You want to know what their cardiovascular risk might be at baseline, but also you're going to want to follow that because both the infection and the drugs may alter the lipid profile. Fasting glucose, again, for the same reason, there's an increased risk of diabetes with some of the medications we use to treat HIV, so you want to know what their baseline is. You're going to want to get a urinalysis, again, thinking about screening for underlying renal disease. The recommendations are certainly to check a urine protein. You're going to want to screen your patient for hepatitis A, B, and C. You want to screen for any other underlying STDs. And women, you need to do a screening pap smear. Now let me see, looking at some of the responses, CBC, CMP, I agree. Genotype is another one, retesting with a Western blot. So the Western blot is the confirmatory test. So if someone is positive on the ELISA, which is the screening test for HIV, yes, you always want to confirm it with a Western blot. My assumption on this patient was that her screening test was confirmed with a Western blot. Okay, so I always get questions about what's the resistance test you should do for your naive patients, your patients who have just come into care. Do you do a genotype or do you do a phenotype? And if you talk to different providers, you may hear different rationale, but I would say a majority of us will go with a genotype. Remember, the genotype is just going to show you the mutations. It's not going to tell you specifically which drug will work and which drug won't. You're going to get that inference from the genotype, but the phenotype is really the sort of the culture and sensitivity. If we use the analogy to a bacterial infection, the phenotype is more analogous to that. That being said, the genotype is a much easier test to do. The results come back much quicker, and it's much lower cost, and certainly for patients who have never been on antiretroviral therapy before, it's probably going to give you the same amount of information as the phenotype, a lot quicker and a lot cheaper. So the answer to which one do you use, certainly for a new patient, is pretty much a genotype. So let's talk about the drugs, and I kind of went through this before. There are really 6 different classes of drugs that are used. The top 2 basically work on the same piece of the life cycle of the virus. They work on reverse transcriptase. The protease inhibitors obviously work on the protease enzyme. The fusion inhibitors work on the area where the virus actually fuses to the CD4 cell before it enters in. The entry inhibitors block those co-receptors, and then integrase inhibitors block the integrase enzyme, which is the enzyme that's responsible for integrating the viral DNA into our DNA. Now, these maturation inhibitors that I mentioned have been in development for a long, long time. I mean, probably more than 10 years, and we haven't really found a suitable candidate, but that's still always listed as a potential target. So what is HAART? I kind of mentioned that before. And this is analogous to treating tuberculosis. You can't just use one drug. Many of us who have been doing this for years went through what we call serial monotherapy, where we treated patients with one drug until a new drug came out and then added the new drug. And we learned very quickly that this virus is very smart and rapidly becomes resistant to drugs. So the best way to treat this virus is to use combinations of 3 drugs, and generally we use them from at least 2 different classes. So I kind of disagree with this slide. It's a little older. There's no data that supports using more than 3 drugs. They've looked at combinations using 4, 5, and 6 drugs. It's no better, and in fact it's much more toxic to the patient. So we use 3 drugs. We try to do at least 2 different classes of drugs. So for instance, a reverse transcriptase inhibitor plus a protease inhibitor. So you may use 2 drugs that inhibit reverse transcriptase and 1 that inhibits a protease. Or you may use 2 drugs that inhibit reverse transcriptase and 1 that inhibits integrase. So there are many combinations, and we'll get to the recommended combinations shortly. So let's get back to our patient. So she has a viral load, that's HIV-1 RNA's viral load of 7,000 copies per ml. And just to give you a point of reference, I've had patients who presented to me with viral loads of 1 million or 1.5 million copies per ml. So 7,000, I would say, is kind of on the low end. Her CD4 cell count is 495 cells. Normal depends upon your lab, but generally is above 500. So what would you recommend about starting antiretroviral therapy? So this gets back to the guidelines, which we talked about before. And I think before we go on to the recommendation of the therapy, I mean, I think now, you know, assuming the patient doesn't have other issues going on like substance abuse or is homeless or you know, it hasn't disclosed her illness to her family and support system, most of us, going by the guidelines, would recommend that she start antiretroviral therapy at this point. Her CD4 count is less than 500. Anybody have any questions on that before I move on?
It takes a few minutes for the questions to show up in the queue.
Okay. Well, I'm going to go on, and if any questions appear, I certainly can answer them. So these are the current recommendations for regimens to treat patients who have never been on antiretroviral therapy before, and they're really based on four sorts of categories. The use of non-nucleoside reverse transcriptase inhibitor. So this is using efavirenz plus 2 reverse transcriptase inhibitors, nucleoside reverse transcriptase inhibitors. So 3 drugs, 2 from one class, 1 from a different class. You'll ask me, well, why they all have the same target? It's true they all have the same target. They all work on reverse transcriptase, but we know from data that this is actually a particularly good combination. It's a nice combination because this combination of all 3 medications for the last several years has now been available in one pill, and it's a once-a-day medication. So many of you may have seen the drug company advertising one pill once a day. This is the pill. And fortunately now we have another one pill once a day combination that I'll mention in a minute. So this is a particularly good combination. It's very effective, and it is the most commonly prescribed combination in the United States. There are some issues with this combination. The biggest issue is that if you have a patient who is a woman of childbearing potential, someone who may not be using adequate contraception, you do not want to give this combination because the efavirenz is a pregnancy category D drug, D as in dog, which means that it is teratogenic. And while there haven't been any documented cases in the registry of birth defects, it's not anything any of us really want to take a chance and risk. So since there are other combinations, this is not recommended for women who possibly could become pregnant. So the other combination uses what we call boosted protease inhibitors, which are the drugs that inhibit the protease enzyme, plus 2 of the drugs that inhibit reverse transcriptase. And these 2 combinations, the ritonavir is actually a boosting agent. So this is actually a 3-drug combination. I'm sorry, a 3-pill combination, but it also can be given once a day. And then we have 2 different protease inhibitors that are recommended. The darunavir, ritonavir, and tricidibine and tenofovir is also a once-a-day regimen, but the darunavir is 2 pills. So this would be 4 pills taken all at the same time. This would be 3 pills taken all at the same time. You can use a integrase inhibitor plus that same combination pill. And then for women who are pregnant, this is the recommended combination. It's an older combination, but it has a very long safety history, so we don't have to worry about birth defects. So the things that providers need to be aware of when you're starting the patient on antiretroviral therapy is the most important thing is that every patient is an individual and you need to individualize therapy. And things are a lot different now than when we only had 1 or 2 medications to prescribe. We now have about 30 different medications. And so you need to carefully look at your patient and customize the medications for your patient based on some of the parameters that I've listed here, but this isn't everything. How effective the drugs are going to be? Well, virtually all of the drugs now, if they're used appropriately, are equally effective and equally potent. But they have different toxicities. As we mentioned before, there's different pill burdens and dosing frequency. We always have to be concerned about how drugs will interact with each other as well as with other conditions the patient might have. And then, very important, you have to use your resistance test, your genotype, as the roadmap to determine which drug to use. So I mentioned before the preferred backbone is either efavirenz, a ritonavir boosted PI, or raltegravir. There is a new drug that just was approved this year, rilpivirine, which is another non-nucleoside reverse transcriptase inhibitor like efavirenz. It also has been co-formulated into a 1-pill once-a-day regimen. One of the nice things about the rilpivirine is it doesn't have the teratogenic effect and doesn't have some of the other side effects that the efavirenz has, although you know, there's a double-edged sword. Rilpivirine has its own issues, but it's another 1-pill once-a-day regimen. That's a possibility for your patient. Again, we go by the guidelines, but again, we need to treat each patient as an individual, and there may be reasons, medical reasons, that may make it more reasonable to delay therapy for a while. I think the biggest issue is the first one, is the barriers to adherence, because we know that the pills work if the patient takes them. They're not going to work if they stay in the pill bottle or in the medicine cabinet. And in HIV, the difference between the therapeutic dosage or blood level and the toxic blood level is a very, very small margin. So it's very important for patients to be taking their pills. There are studies from many years ago that show that patients really do need to be taking about 95% of their pills in order for the drugs to be effective. The presence of comorbidities are important, but they may delay therapy, but usually you can get by that, especially with the new drugs. And I think the bottom caveat, the delay of antiviral initiation, is only for patients with higher CD4 cell counts. We need to really be starting our patients earlier. Adherence, we mentioned, very important because it's correlated with all kinds of things, but most importantly with increase in survival. And if you don't take your pills, you're more likely to develop resistance and failure of the drugs. Okay, factors that are associated with adherence. Again, these are some of the things that you all deal with. A lot of these are the social determinants of health. You know, what is the home situation like for the patient? Do they have enough to eat? Are they working? Do they have insurance? Does the people they live with know about their disease? Do they have a good relationship with their provider? And do they have a team that takes care of them? Those are all very important factors that are associated with adherence to medication. Depression is a risk factor for non-adherence. There are lots of studies out there, and they keep getting repeated, and I think the HIV providers are finally getting the message. But this is just quoting one study that shows that that adherence was lower among depressed patients who were not on antidepressants versus patients who were treated with antidepressants. I don't think that's surprising to any of us who take care of patients with chronic illness, that you need to be aware of mental health and you need to address mental health issues, but very important for HIV. We talked about this before about adherence, here showing that even with more than 95% adherence, there was still 21% of patients, or almost 22% of patients, who failed their regimen. But then if your adherence goes down to 70%, your failure rate goes up to 82%. It's a huge difference. And why do patients get resistant? Well, HIV is a very smart virus, and but it doesn't, because it reproduces so rapidly, it doesn't do a very good job of copying itself. So it mutates almost every time a new copy is made. What we call the wild-type virus, which is the virus that's out in the community, is really the most common form of HIV, but anything different from wild-type is really considered a mutation, and the virus will mutate when the patient is not taking an adequate amount of medication. Okay, back to our patient. You've consulted with her, and the patient and you, both of you, agree, because the patient needs to buy into this, that she should start on therapy. Would you want to do any additional testing at this time? And I'll wait a few minutes to see if anybody wants to respond. Someone asked if we got our baseline labs. Yes, we did. I haven't told you them, but we got them. So let's go on here. So additional tests that this patient would get, someone wrote a liver function hepatitis screen. Yep, those were part of the baseline test. We got those. So the only other thing I think that I would probably want to do on this patient would be, because she's a woman, I want to make sure I did a pap smear. Don't forget that there's an increased risk of cervical cancer in women who are HIV positive, and that risk does not really decrease back to baseline even if they go on antiretroviral therapy. So I think that would be the other tests that I'd want to do at this time. So assuming you put this patient on her antiretroviral therapy, what will you do for follow-up? And what kinds of tests are you going to be doing to follow her? So I'll wait a couple of minutes for folks to think about that. Good. Yep, see, some of you obviously are taking care of, oh great, lots of responses. So yes, you're going to follow this patient's CD4 count and viral load, but you're also going to want to monitor for any toxicities. So generally sort of the routine screening would be CD4 count, viral load, CBC, as a minimum liver profile, but most of us order a whole chemistry panel or CMP on a regular basis. So how often would you monitor this patient? Generally, once you start the patient on antiretroviral therapy, you want to see them soon afterwards. I generally either bring my patients back or at least have someone talk to the patient 10 to 14 days after starting the medication. You want to get an idea if they're having any problems with the medication, check on their adherence, ask about side effects and toxicities. I usually bring patient back in a month or so, and at that point we'll do as a minimum a viral load, because you'd expect to see a significant drop in the viral load. You may not see a CD4 cell bump, and that may not happen for a couple of months. And then assuming that they're doing okay, not having problems with medications, you'd probably see them in every 3 to 4 months. And as they do better, and many patients now are doing quite well with their regimens, there are new recommendations that every 6 months for very stable patients are perfectly fine. There are additional tests that you're going to want to do. This is a woman. I'd probably want to do a pap smear twice a year for at least a year or two once she's on the antiretroviral therapy. And then assuming they're normal pap smears is then probably once a year. You're going to want to check lipid panel. You're going to want to do check urinalysis for protein. You're going to want to check renal function on a regular basis. So there are a number of guidelines around how to follow these patients. Just to review a couple of things now about factors that are relevant to selecting the regimen the patient's on. Baseline viral load, and that's really if it's a viral load that's under 100,000 at baseline or above 100,000, because some of the medications don't work as well at high viral loads. Comorbid conditions, huge issue these days. Again, we mentioned what other drugs that they're on, pregnancy or pregnancy potential, their genotype testing, and then other sort of less important factors depending upon if you're going to use drugs that we don't generally use for new patients who have never been on antiretroviral therapy before. This is just a composite list of potential possible side effects of antiretrovirals. This is, you know, if you're going to be prescribing the drugs, you need to know what are the side effects of the drugs that you're using. So this is a laundry list, but it's just to remind you that these drugs are not without side effects. I'm just going to touch on some special issues. HIV in women, we've kind of mentioned already. Pregnancy is a issue, and it will guide your decision of when to treat and what to treat with. Women tend to have a lower viral load at a specific CD4 count, so the viral load actually may underestimate the amount of disease a woman has. We're not really sure why. As women age, and this kind of gets into the HIV and aging, issues around osteoporosis, early menopause become more important. The issue of HIV and aging I could spend a whole hour talking about, but suffice it to say that by 2015, over half the HIV-infected patients in the United States will be over the age of 50, and in some cohorts that's already happened. And as you age, you get other illnesses and you take other medications. So there's a whole research and recommendations being drawn up now on how to approach older patients with HIV, which for most of us will be most of our HIV population shortly. And then HIV and comorbidities, well, we talked about hepatitis. We haven't even touched on things like diabetes, hypertension, and renal disease and liver disease, but those also are topics that you know, are becoming more important, more common, and need us to be really cognizant of what some of the issues are around treatment and prevention. I'm probably not going to spend a lot of time on HIV in women, but women with HIV is increasing. It's mostly through heterosexual contact. Many women with HIV are low income. I live in Florida, and you can see here that the data of women of childbearing age account for, you know, almost 2/3 of all cases of HIV among women in the state. And we already talked about the viral loads and CD4 counts in women. Okay, here's a test question. Which age group has the greatest % increase in AIDS cases between 2000 and 2004? And I'll actually tell you that you could make it between 2004 and 2010 because the data hasn't changed. Is it the folks between 13 and 19, 20 and 29, 30 and 39, 40 and 49, or those over the age of 50? I'll give you a couple of minutes to think about that one. While you're thinking about it, someone asked about the urinalysis. It's a screening test for early renal disease, much in the same way we use it for diabetic nephropathy. So the answer to this question is actually the let me grab my little arrow here. Nope, it's the over 50. They're the group that's gaining that has the greatest % increase in age cases. And part of it I already alluded to. It's mostly because this group of patients got infected 15, 20 years ago. Now with the regimens have done really well and have actually aged into that. But unfortunately, this group also has an increase in new cases too. So it's the older HIV patient. I'm going to skip this. This kind of talks a little bit about how we track disease progression. We kind of went over that already. Life expectancy. I will tell you that the current data is if you are 20 years old and unfortunately get infected with HIV and you get into care and stay in care and get treated, your life expectancy will be very close to a normal life expectancy. The disease is not the death sentence that those of us who've been treating remember from a very short time ago. That the major determinants of survival are, I believe it's actually access to care is number one, and number two would be adherence, and then the third would be response to HAART. But we also know that the older you are, the less, the lower the life expectancy. And then there are some other markers that are being looked at as markers, including whether or not you have anemia and whether or not you have liver injury. Just to tell you that comorbidities are probably as a result of the disease, but also the treatment plays a role. And those of us who are treating patients who've been infected for a long time are seeing lots of liver disease, heart disease, renal disease, bone disease, and malignancies, particularly not the ones that we used to associate with HIV, like Kaposi sarcoma, but things like lung cancer that we never really associated with HIV. So I'm going to wrap it up to allow a little time for questions. That I hope you get away, come away from this that the treatments for HIV has really increased the lifespan of patients in the United States. We didn't talk about what's going on in the rest of the world. That really we need to routinize screening for HIV, and prevention still remains a mainstay of preventing the spread of this infection. We have lots of good drugs that target different stages of the HIV cycle. Emergence of resistance is a threat to therapy, mostly mediated by non-adherence, and routine monitoring and primary care is really essential. So I want to thank you. I can certainly make these slides available. There's a good website called Clinical Care Options that you can go on to. They have great slide sets. The CDC is a great source for demographics and data. That's where I pulled a lot of the slides. And some of these actually I got from a Bristol-Myers Squibb slide set. So I think, Sabrina, I am 3 more minutes. So if anybody has any questions, I'd be happy to answer them.
I think we had a few questions in the queue that didn't get answered. There was one about the drugs that do not work with high viral loads, greater than 100,000.
Okay. Yeah, so the ones that don't work as well with viral loads over 100,000, rilpivirine, that new drug I mentioned, the data indicates that that doesn't do as well. People will argue about efavirenz. My own approach is, if someone comes to me with a high viral load of over 100,000, I tend to use a boosted protease inhibitor rather than efavirenz. And then one of the drugs we didn't talk about, abacavir, there's data too there that over 100,000 viral load they don't really work all that well. I think there's another question here about how do psychotropic medications affect HIV treatment. Certainly antidepressants, the SSRIs, there are no interactions, and as I mentioned before, you need to treat depression if you expect your patient to adhere to the medications. Psychotropic medications, I've not heard of any interactions, so you know, I imagine you're thinking about the things like phenothiazines and those sorts of drugs, lithium. I don't know of any issues with those and the HIV medications. Let's see. Do I have time for more, Sabrina?
Yes, you do. Okay.
All right. What is the lowest viral load that can the genotype resisting test? Okay. What's the threshold for a viral load for genotype resistance testing? That question always comes up. It depends upon your lab. We were always told that the viral load needed to be 1,000 minimum, but I have sent off viral loads of patients in the 500 and 600 range, and I've been able to get a genotype back. So it kind of depends on your lab, but you know, if you have a viral load of 200, I wouldn't send off a resistance test, but if it's 500 or 600, I certainly would try it. And clarify something about syphilis treatment ×2, status post syphilis ×2. Not sure what that means. Let's see, maybe, okay. New patient with HIV, undetectable viral load on treatment, Hep C, status post treatment, undetectable quantity, and status post syphilis treatment ×2, transmissible. I think you're asking me, is this patient going to transmit syphilis? So undetectable HIV viral load, of course, it depends on what level you're able to detect the viral load. But you know, most of us are using 48. The risk of transmission is still there because there still could be virus, and I'm assuming this is a male or it could be a female, but there still could be virus in the vaginal secretions or semen. Hep C, status post treatment with an undetectable Hep C viral load, if it's past 48 weeks, it means that they're in a sustained remission, so they're not transmissible. And syphilis treatment ×2, I would assume that you've checked a RPR and there's a declining titer. I'm hoping I'm getting that question right. So if not, let me know. Let's see. Any more questions here? Does the Medicaid cover genotype? Yes. Certainly in Florida, and we have one of the more restrictive Medicaids in the country. It is covered, and certainly if you work in a Ryan White center, there is funding to cover genotype testing. Thank you. Excellent. Okay. He believes he isn't infectious. Okay. So our syphilis patient doesn't believe he's infectious. Yeah, part of it is this whole issue where we tell a patient their viral load is undetectable, their HIV viral load is undetectable. Patient thinks that means that I can't transmit the virus. You can't say for sure that they're not going to transmit the virus. Certainly lower serum viral loads correlate with less risk of transmission, but the risk is probably not zero. So I would tell your patient he or she needs to use a barrier method for safer sex. Okay.
So Dr. Applebaum,
one more, Sabrina?
Should we give them your email address to request the slides? We actually are recording this presentation, and so they will be available on our website in a week or so. But if any of you would like to have it before then there is his email address.
Do you have it there? Yeah.
Yes, and you guys can just request it directly.
Okay.
I think we have a few more questions. I don't know if you're able to see them, so they're coming out now.
Okay. What is your threshold for increasing AST, ALT on treatment? Most of us don't get nervous about increases in liver function tests until they're between 3 and 5 times upper limit of normal. But I would, if I see that kind of an increase in liver enzymes, I'd want to know if there's anything else going on. Is the patient taking other drugs? Does the patient have Hep C or Hep B? So you always need to kind of think about that. Have there been any recorded cases of transmission of HIV with undetectable viral load? Oh, I don't know the answer to that. I've not heard of any, but that doesn't mean that there aren't. Anything else, Sabrina?
I think that'll do it. We got a lot of thank yous and applause for you. So,
okay.
Thanks.
Well, that was great. Thank you.
That was like one of the best HIV talks I've ever heard. It was, I mean, you have a gift to explain such a complicated thing in such a simplistic, understandable way. So thank you very, very much.
You're welcome. I've been doing this a long time.
Well, you do it well, sir. Thanks for sharing your gift with us. And thanks also to our audience tonight for participation, for your questions and comments. I would like to thank our IT team, both Qualin and John. Thank you as well. An evaluation for this webinar is going to pop up in another window if you're using IE, or another tab if you're using Firefox. Please complete it in its entirety in order to obtain your 1-hour CE credit through AAFP. I would like to just highlight our announcements that you guys are invited to attend our Tuesday next week coffee shop, behavior health, around the topic of dual diagnosis. So if any of you are behavior health clinicians or have colleagues that are, then please send them our way. And also you are invited to join us next week, Wednesday, October 12th from 8 to 9 p.m. for another free CE webinar entitled Integrative Medicine and Women's Health with Dr. Ray Teets. We're going to talk a little bit about using alternative medication to treat common women health issues. Again, just remember that this series is made possible through a partnership, which allows us here at PrimaryCareForAll.org to serve as a resource for you and other clinicians who work in the underserved areas. Direct financial support for this webinar series is made possible through a cooperative agreement with the U.S. Department of Health and Human Services, Health Resources and Services Administration, and the Bureau of Clinician Recruitment. Thanks again and have a wonderful evening. Thanks, Dr. Applebaum.